lights gel action.
All right, this is your carotid demonstration.
Okay.
And Lauren.
And Lauren. Starting off in trans. First thing I like to do is scan all the way through. And I get the layout of my vessels. I'm going to start in prox. Proxies you. Oh, look, I can see it coming straight off your brachiocephalic. That's fantastic. Right. This trans prox common carotid. We're going to be able to see all of the edges of your vessel. Clear out your lumen. Center of your screen. Picture. Mid. Your mid-carotid is probably going to be right around where the mid-thyroid lobe is in trans. Your stomach growling. Go up. So to locate your distal, best way is to go all the way up until you get to the bulb and then come back down into the distal carotid. We'll do trans bulb. Again, you can go up until you see the bifurcation. Both the vessels here, ICA and ECA, and come back down. Kind of an ovoid shape to it, and that's going to be your bulb. Do put color on the bulb. Your box orientation should be steered straight up and down for trans color imaging. And you'll get this yin-yang flow pattern in the bulb. If I'm not articulating this very well, just let me know.
Oh, I think it sounds great.
Okay. And next is going to be our bifurcation. You may have to slide around on the lateral part of the neck if you're getting shadows that are covering where you're supposed to see everything. If you're getting coming off of the muscles in the neck, then slide around and up until you can see both of the vessels separate. I'll put color on that as well. Invert my color. Now we're going to be doing the long images with color and pulse wave. You'll come back down in trans, follow it back down to where it comes off of the brachiocephalic. Now rotate your probe. Oh, sorry, Lauren.
Turn too much.
No, you're good. It's just no more gel on it. echoes, but you don't want it to be so dark that you're going to lose the vessel walls. So you want your vessel lengthened all the way out across your screen. You'll be able to see the walls, no echoes in the lumen. So now you're going to steer your box the direction of your vessel. So because my vessel is oriented across my screen this way, my box will follow my vessel. If I were to change my approach and make my vessel go this way, the box is going the wrong direction if it's oriented that direction. So we need to steer it this way. So the edges of your box are going to point in the direction that your vessel is traveling. I don't like my angle that way, so I'm going to fix it. You need your scale high enough so that you fill the entire vessel wall to wall. You don't want overfill. And this blue and yellow happening here, a little too much aliasing for me, so I'm going to turn my scale up. And then my gain slightly down.
And usually your scale to your color flow is approximate to what your velocity of your that vessel is. Pulse wave, and stay in the same spot. Alright, so here I have my angle or my gate centered in the vessel. Alright, so the gate centered in the vessel, and you're going to adjust your angle, keeping it under 60 and above 30. Right, now you're going to go ahead and raise your scale. Be able to see the top of your peak in your systolic flow. You have a nice clear spectral window telling me I'm in the very center of my vessel. That look nice and pretty. All right, so see my angle is parallel with my vessel walls. We're going to measure, put it in the package under Crocs. Measure the peak systolic, the very tip of that pulse wave, and end diastolic directly before the next upstroke. Mid, and you'll repeat that all the way through.
And you'll notice on the left-hand side it's being put into the package. It's like a little check mark for you.
Now we just repeat that all the way through. If you need to go back into trans, orient yourself in the midsection of that vessel, that's fine. So we'll go back up here. I can see lobes, so I know I'm mid. Clear my lumen. And your box should be the size of the vessel, of the section that you're doing without being, how do I change my box? Here we go. So we don't want this. All of this space up here, this is all unnecessary. It's wasted space. We're not imaging anything here and here. We're just imaging this section of the vessel. So just outside of the vessel walls, because we want to make sure there's color fill from wall to wall. And we don't want it all the way across our screen. Again, we're just taking a segment of mid. So that will be where we leave that on. And I'm going to steer first before I adjust my angle. And then
measure, same thing, you're going to put it in the package. Peak systolic and diastolic. And same thing for distal. You can go up to the bulb and lengthen it out. Some cases you'll see this dilation happening here where you can separate the vessels. Sometimes it'll look very similar to the distal's diameter. But if you can go up to bifurcation and see where it splits, and then you can differentiate the distal and the proximal ECA or ICA from the bulb itself. So here we have distal CCA, bulb, prox ICA. Now I can turn my scale back down a little bit. Because the velocity has changed somewhat, so we don't need our velocity scale for pulse wave set at 160 when the peak velocity is in the 90s. So that was close, 89. This here is the bulb. So you'll place your gate right there in the center of that bulb.
Sometimes you have to drop your scale so you can pick up that lower flow in the bulb. So there might be some aliasing. There it is. I see it peekabooing.
And I'm like, can't get it to do it. So you'll end up with some of this sort of turbulent like flow. These are considered like the eddies here. So that blood is kind of swirling as it's separating into the two different vessels. So it's normal to get that. It's not all red across your screen.
In the literature, it calls it helical flow.
Helical flow, not turbulent flow. You are correct. I think Dara told me that on Tuesday, actually. So we still want to make sure that we're keeping our vessel open end to end here. Steer. In the bulb. Now, ECA, I'm not pushing too hard.
Mm-mm.
Now ECA and ICA, we'll start with the ECA. ECA is a vessel that provides flow to the face. So to help with your orientation and somebody who doesn't have any vascular anomalies where the vessels crisscross or anything like that. So normal orientation, you would angle your probe towards the patient's face or jawline.
You can actually see her branch coming off. Look at her superior thyroid.
Right here.
So many you can't see, but hers you can see really well.
Beautiful. All right, so that's how I'm going to be able to tell the difference. This is got a branch coming off of it in the proximal part of the vessel, and I'm angling more towards her jawline or towards her face, which is where the vessel supplies. So that's going to be my ECA. If I angle slightly back towards her ear, towards her brain, we get the ICA, which is the vessel that supplies the brain.
And you'll never see a branch coming off of the ICA.
do not use diameter alone
No, sometimes they're equal.
to determine which one is which, because sometimes they look the same and sometimes it's reversed. You might have a very thin diameter on an ICA and a very large diameter ECA. So it's all about the anatomy and the orientation of that vessel, and you also want to pay attention to your waveform.
And on a normal anatomy, that's kind of how I remembered it, is your face is external or on the outside of your body, so most of the time you're angling in towards your face, which is what it feeds. Your brain is internal, and so your ICA is going to feed your brain, and it's more lateral on a normal anatomy person.
And when you're lucky enough to see one that looks like a tuning fork,
Yep.
you know your day is good.
If you can get both, that's even better. Beautiful. There's her branch right there. See, my vessel is going this way, so that is where my box needs to go. Not to push hard on your neck. I feel like it's
No, you're
pushing
fine.
on it.
It's not pushing too hard.
You don't want to choke out your patients. That's not a good look. There we go.
Sometimes you have to go out lateral and angle back too to get the vessel to open up. I think her ECA must be tortuous. It looks like it goes anterior and branches up. Or is that the ICA coming down? I don't know, one of them. I think it's, yeah, the ECA kind of goes more anterior, doesn't it?
Yeah, so I have to come more forward on her neck. Now I've got better color fill.
Yep, so you gotta try both ways. You just never know.
There. That's much better.
Beautiful.
So whereas I was further back on her neck, more posterior, trying to angle towards it, I wasn't able to achieve the angle just because of the direction that her vessel goes. So I came more forward on her neck and located it this way. And now I've got a better view of her ECA.
So you have to try all the tricks of the trade.
Yeah, every neck is going to be different. Vessel open, proximal segment. Alright. On the ECA here we have a sharp peak systolic here. You'll see when we do the ICA, this diastolic. Now, in some of the patients that you'll do, like in the clinic settings in the hospitals and stuff, they're not generally the healthiest of people. So you may not get any diastolic flow at all. You may just get a real sharp peak systolic and very little to no diastolic flow. But this is going to show more of a higher resistive flow. So when we do the ICA, you'll see that this diastolic velocity should be a little bit higher. Hey, where's my...
Oh, go up to the side. I don't know why it's not on the, or hit. I go up to the side panel with my arrow because you have to scroll down to see it for whatever reason.
Oh, okay, I see. Over here.
I don't know why it's not on the, yeah, I don't know why it's not on that screen right there, but
Where is it?
right there, go down.
Did I miss it?
Yep, go down. Right.
Oh, here it is.
Yep.
Okay. Well, that's weird, but okay. So from here, I'm going to angle towards her brain, towards her ear, however you want to see it. And you want to see it coming off of the bulb. So you see here this diastolic is a bit higher, and this systolic is not quite as sharp of a velocity peak.
Remember, the ICA, the waveform takes longer in time. Remember, going from left to right is the time. And so the ICA takes a longer time for it to rise to peak systole and to drop to diastole.
Is that because it's more of a continuous flow?
Yeah, it's because
You want
the bed that it's
flow
yes,
to your brain.
Yes, it's because of the bed that what it's feeding.
All right. So we're gonna slide a little bit further superiorly on her neck, and here we're gonna get mid. You want to get as distal on the vessel as you're able to achieve. On her, we can see hers diving all the way down here. Hey, does anybody know what that is? Just out of
The parotid gland?
I was like, does anybody maybe know? Just out of curiosity? The parotid.
Maybe you weren't asking the teacher. Who were you asking?
I was asking the viewers. Alright, so I pretty much hit her jaw here. So that's as far as we can go. That's going to be distal for you. And see how sharp of an angle that I have on my vessel here? You don't want your box straight up and down, but you can use the steer, so it's going to be less of a dramatic steer on your box, and make sure that your angle, you can make fine adjustments to your angle and make sure that you're straight in that vessel. This must be a lot changing. That's on one color scale. There we go. Does that sound like crickets to anybody else?
Yes, I was just thinking about that.
You have a cricket in your distal ICA. Alright, I am going to adjust my angle just a smidge. There. Alright. how high this diastolic is here? Further it goes into her brain, the least amount of resistance that you're going to want. All right.
Vertebral.
Last part is the vertebrals, which is a personally very satisfying image to get when you can see it beautifully. All right, so vertebrals, a couple of different ways you can do this. My best suggestion approach is going to be come back to prox, common carotid, turn in long, and then you're going to angle out till you see these vertebral bodies here.
I mean, it makes sense. You're angling to the vertebral bodies on the back of their neck, so.
And if that, coming from this forward position here, you can always slide around on the more posterior side of the neck. Now I've got a little bit better view here. Now I can see it more clearly.
And sometimes, occasionally, you have to put the patient's head straight up and down to get it, especially if it's an older person that has, like, you know, disease in their spine.
Yeah. So these are the vertebral bodies here that are going to create this shadow, and then the artery runs in between these bodies. So you'll see it in segments in between these here. So really you just pick one that you can visualize the best and take that sample.
Plus, just know that there are some of our clinical sites that make you do proximal mid-distal on vertebral. So when in Rome, do as the Romans. Here you will only be obligated to do one.
All right. So because of, we always telling you want color to fill edge to edge on your box. Well, this shadow off of the vertebra is what's keeping that color from going edge to edge here. So this is fine. As long as the visible portion of the vessel that you have on your screen is filling with color, that will work. Ooh, this is why it's my favorite. Wait a minute. I can get both.
And if you notice distally, her angle is more natural, so you might get a better waveform at that distal one.
I really like this picture personally.
It's gorgeous.
It's just pretty.
I can't reach your back, but I'll get it in a minute. Pat you on the back.
All right. I get this one. I like this one better.
And remember, the vertebral is a little bit slower flow, so your velocity scale is going to go down with vertebrals, unless you have a stenosis. Gorgeous.
Alright. And get this one put in the package as well.
And then she's going to show you how to do the package, and then of course you'll do the other side.
Lather, rinse, repeat for the other side.
You want to show her how to do the package?
Yeah. You got it?
Yeah.
Okay. Alrighty. So then, where did we go for this?
Right hand side. Up top, up top, up top.
Oh, got it. All right, so you'll hit the ICA CCA there, and then this button ICA CCA ratio. It's going to bring up your list, proximity to distal on the CCA and the ICA. So we're going to pick the highest ICA. All right, so her highest ICA is actually in her proximal. It's 103. So we'll enter that in there. And then
You can also just choose the little button.
oh, hey, yeah, you could probably do that too. Okay, cool. And then you're going to choose your distal CCA ratio. And then it's going to give you your ratio here. All right.
Thank you very much.
Thank you. Thank you, ma'am.